let us go to the definition of cardiac rehabilitation. Cardiac rehabilitation is a sum of activity required to ensure cardiac patients the best possible physical, mental, and social conditions so that they may, by their own effort, regain as normal a place in the community and lead an active life. What are the goals of cardiac rehabilitation? The goal of rehabilitation is restoration of optimal physiological and vocational status and reduction of cardiac morbidity and mortality. Now, how is this program delivered? This program is delivered by specialist nurses who have undergone courses in therapies, physiotherapists led by experienced clinician, usually the cardiologist. The main focus is on monitored exercise and aggressive risk factor reduction in medically supervised sessions, together with reduction of anxiety and depression. Anxiety and depression, to decrease it, that is the primary aim. Now there is a large area, it encompasses a large area, but what are we going to dwell on is psycho-behavioral management. This doesn't seem to work, this is not working, so we are going to base our talk on psycho-behavioral management. The patients with refractory angina have persistent anginal pain even with the maximal therapy. Poor general health, psychological distress, restriction of activity, inability to self-manage their symptoms, and all cause negative effect on health-related quality of life. So how do we rehabilitate these patients? This is done with a very unique type of rehabilitation known as pragmatic rehabilitation. What does that mean? It means self-therapy or practical rehabilitation. This is an important approach for patients to manage their own chest pain. So before we start this rehabilitation process, it is made very clear to the patient that angina will never kill, one. Second, other than angina, any chest pain is not always angina. There are other factors which can be causing the chest pain. So with this premise, this pragmatic rehabilitation process is started. Now this pragmatic rehabilitation consists of two parts. One is the education part, the second is the lifestyle adaptation part. When we come to the education part, it has two therapies. One is the cognitive behavioral therapy, which was started in 1997 in Liverpool, and the second later on started as the York Anginal Plan. Now let us understand something about the cognitive behavioral therapy. Cognitive behavioral therapy is a self-managed technique challenging negative health beliefs to improve quality of life. It improves psychological well-being, mainly anxiety and depression. How is it done? It is usually clinic-based and a hospital-based therapy. Patients with refractory angina are grouped together and they are asked questions about what matters to them, what is causing them pain, what is causing anxiety, what is causing depression. And all this is written in the form of a questionnaire, and then according to the latest available knowledge, the answers are provided to them. And that apparently brings down their anxiety and depression. If you don't know, the other way is to understand, you will yourself in that area understand what are the likely questions they may want to know. For example, this questionnaire, patients' view on regular exercise, whether angina damages the heart, whether they thought they ought to avoid provoking episodes of angina, or whether avoidance of angina will reduce the risk of MI. And then you provide them the latest available scientific evidence to them, and then this decreases their anxiety and depression, and that is the main aim of this therapy. So the education is to correct the common misconception about angina, and then always dispel the idea of death. When refractory angina comes, always the death comes into beat, and challenge them with the optimist registry of 1,200 patients, which showed that 71% of patients with refractory angina have a 9-year life expectancy. So it is not that bad. And this is the slide which shows just after 1 month of cognitive behavioral therapy, the hospital admissions have come down. And this was a study which was done after 1 year of starting of cognitive behavioral therapy in 271 patients, where we see that the incidence of MI has reduced to 8 patients from 32 patients. The total hospital admissions have come down to 1.7 patients per year from 2.4 patients. The total hospital bed occupancy has also reduced from 10 to 0.34 patients from 15.48 patients per year. The total non-cardiac admissions being remaining the same. So when this was the result, it was thought that why not integrate it with the secondary preventive therapies available at that time. And it was first time in the city of York in the United Kingdom that this was integrated in 1991, and it was known as the York Anginal Plan. So in the constituents of the York Anginal Plan, the basic thing is the heart manual. This is a 70-page manual which gives the common misconceptions and the latest scientific answers to that. It also contains good explanatory written, audio-taped education material, stress management advice and relaxation training in the form of CDs, symptom-limited graduated exercise program in the form of a CD, and homework-based York Anginal Plan, which consists of learning how to pace oneself, setting realistic goals, deconstructing tasks into manageable portions. So breaking work into small parts so that the patient does not get stressed, together with adherence to aggressive primary and secondary prevention. Now, how is it managed? Usually this is a 3-tier program. First, the patient goes to the primary health center where the nurses and the primary doctors take care. This is a 3-month program. If there is not much of an improvement, judged by the hospital angina and depression scale and the Seattle Anginal program questionnaire, if there is not much improvement in this, then they are sent to the secondary centers where the cardiologist and the pain teams work. And if there is not much improvement after 3 months, then they are sent to the regional refractory angina centers in the UK, which they are set up in different parts of the United Kingdom. In India, we don't have such a system of refractory angina centers. Now, what does the sisters or the doctors do in the primary center? Usually for the first 12 weeks, that is in first 3 months, it is divided into the first month and the next 2 months. The first month, there is a 2-hour consultation every week for 4 weeks. That is, for 1 month, there is every 1 day of the week for 2-hour consultation. This is divided into hour and hour. In the first hour, the CD-based therapies are discussed, which was present in the heart manual, together with the patient's misconceptions. The second hour is devoted to patient's therapy, what medications he is taking, the frequency of angina, the amount of fruits and vegetables in the diet, and also what to do if the pain increases by more than 20 minutes during the program, and then which hospital to go in suspected myocardial infarction. After the first month, in the next subsequent 3 months, every week, in week 1, 4, 8 and 12, they are given 40 minutes consultation by phone or by personal visit, just to know how they are doing, the intensity of pain, how much they are progressing. If they are progressing well, then they are given encouraging advice. If they are not able to progress, find out the cause and then try to rectify it. And then review after 3 to 6 months individually by the health nurse. And this is the study what they got. This was 7 randomized controlled trials which was evaluated with 949 patients. They found greater reduction in anxiety, depression, frequency of angina reduced by 3 episodes per week, use of glycerol nitrates also reduced, increased consumption of fruits and vegetables, increased frequency of daily walking, and improvement in physical limitation. The base is the heart manual. So in the patient, if he doesn't want to come for this group therapy, there is always home-based cardiac rehabilitation programs available. And for this, there is a 6-week intervention available, uses written material and relaxation CDs delivered by trained healthcare facilitators who makes home visits. And it is just as effective as home-based, group-based programs. Other therapies available, our own India, this yoga therapy is a rising star. It consists of meditation and asanas. It also uses pranayamas like Kapalabhati, Anulom Vilom, and Nadi Shodhan. The problem with this is there is no standardization. Trainers are not standardized. The procedure is not standardized. So it's very difficult to compare from one hospital system to the other. So we know that yoga increases heart rate variability, reduces atrial fibrillation, reduces angina episodes and longer exercise time. And a study after 3 months in one center showed no change in rates of MACE, improved physical activity and mental status, and a tendency for improvement of an LV function with no significant value. Now the other very important thing which I should mention is, now with so much of data, with so much of data, where do we stand? We know that this self-medication therapy carries an evidence of moderate. That means the evidence is not strong because the numbers are small, the amount of randomization is not clear, and the duration of trial is short. So unless and until we have large number of patients, longer duration of study, and a good randomization, this data will never be strong. So this was the editorial with the American Heart Journal, which commented that it is commonly observed that emphasis on technological intervention in the management of refractory angina has led many to overlook critically important aspects of high quality care. Chief among them is education of these patients. So education in patients of refractory angina is extremely important. Thank you.